Hi, everyone, and thank you for joining this webinar where we will be focused on the persistent problem of child mortality due to HIV/AIDS, and specifically the need to improve monitoring and management of advanced HIV disease, AIDS, among children and adolescents. My name is Sharon Ann Lynch. I am the co-director of the Center for Global Health Policy and Politics at the O'Neill Institute, based at Georgetown University in the US. I'm also a proud member of the Fight AIDS Coalition. This coalition, and we have members here, both Florence and Edna, that you'll hear from, have been banging our heads up against the walls to get global health leaders, and specifically the HIV community, to acknowledge, talk about, and fight the drivers of death among adults, children, and adolescents. The Fight AIDS Coalition, working along with many others, have been pressing for action and accountability. Accountability in terms of talking about what is otherwise unnecessary and invisible suffering and death. We know that in the HIV community, we need to impress upon global health actors, the donors and governments, that the progress on HIV continues. But at the same time, we cannot render invisible children, adolescents living with HIV and dying of AIDS-related causes. We have with us some speakers, and we're going to start with Dr. Nandita Sugandhi with WHO, who will walk us through what we're facing. But I have to say this, right now there is one AIDS death every minute. It's actually more than that. But this has been the same statistic for the last few years. We need more. We need more action sooner. The HIV Policy Lab, which is a joint project of the O'Neill Institute, GNP Plus, and UNAIDS, has been tracking policies for HIV, including advanced HIV. We see that many countries are out of step with WHO and international guidelines and norms. Where we are weakest in terms of practice is when it comes to children and adolescents. So, Dr. Nandita, over to you, please.
Great. Thanks so much, Sharon Ann, and thanks so much for inviting me to speak today. I'm just going to put my slides up here. And are you able to see these?
Yes, okay. That's great. Thank you.
All right. So again, thanks everyone for joining. I wanted to talk briefly about the Stop AIDS package for pediatric advanced HIV disease. So I'm going to start by sharing a little bit of background on AIDS-related mortality in children living with HIV, and then talk about the rationale for putting forward guidance for advanced HIV disease, and then we'll review what the actual Stop AIDS package for children holds. So I want to start by just presenting some of the good news, is that the availability of antiretroviral treatment over the last 20 years has averted almost over 20 million deaths. Really, if we look at the turquoise line down here, this is the sort of rate of AIDS-related mortality. But if we see look at the orange line, we can see that's the counterfactual. So if we had not scaled up ART, that's the level of mortality we would expect to see. So I want to start again with the good news that we do have treatment has really been able to avert millions of deaths over the years. And we've had better and better treatment. So I can't, I do want to mention our treatment has gotten better, and we've been able to expand better treatments to all populations. So I know very recently in the last few years, there has been a tremendous scale up of dolutegravir-based regimens. And while at first we didn't have options for younger children, or we also had some concerns about the risks of birth defects with dolutegravir. We now have a lot more evidence, and there has been a lot of investigation to ensure that dolutegravir is safe in pregnancy. And we now also have formulations that enable us to give dolutegravir-based regimens down to the youngest infants. And so really some of our initial barriers to providing optimized treatment for everybody have really been overcome. And so I just want to again point out that, scaling up ART to everybody is still very much a priority. But we also think about the elimination of vertical transmission or the elimination of new pediatric infections. And I want to show here a graph that shows over the years how we've done in both scaling up antiretroviral treatment to pregnant women, as well as our reductions in the new vertical transmissions. And you can see here in the green bars, this is the coverage of ART in pregnant women. And starting from about 2014 or 2015, we really see that we stalled, and we're only reaching about 80% of women who are living with HIV and pregnant or breastfeeding with ART. So that means 20% of women are still not receiving the most important intervention to prevent vertical transmission. And likewise, we see in the orange line here that we haven't had much of a reduction in new vertical infections. So I think this is a graph that many of us have seen before, and we really look at this and think, we've stalled and we need to make progress. But I also want to point out that it's not just progress moving forward, but we have all of these children that we need to both identify and make sure that they are on treatment and retained in care. And the reason why this is so critical for young children and infants is because we know that children have high early mortality. And this is older data. So this is from, early 2000s, but this is not something that's changed. We know that to this day, children who do not receive treatment, who are living with HIV, who were either born or acquired HIV shortly after birth, by the time that if they don't receive treatment, half of them will die before the age of 2, and that mortality increases over time. So we know that this is a vulnerable population. And we know that we've lagged behind in PEDS treatment coverage all this time. So this is, not, again, not something new. I think this is something many of us have heard before. We have seen incredible progress in ART scale up, and particularly for adults, when we look at the 90, 90, 90 or 95, 95, 95 targets, we just really have not gotten there in children. And though we're reaching that for adults, we still have a ways to go. And so even though at this point in time, in 2024 now, we have about 30 million people on ART worldwide. And even though children, and we define children here as under the age of 15, they only account for about 3 to 4% of all people living with HIV. And yet they account for about 13 to 14% of AIDS-related mortality. So it's a relatively small population that disproportionately has a high rate of AIDS-related mortality. And I want to go back to just when we say pediatrics, who do we mean? And the reason I'm doing this is I think as pediatricians, we think about these categories very easily, but I don't think this is always very well explained. So we always think of infants as being, as those that are in the first year of life, and we define children as those that are between the ages of 1 year and 9 years, and adolescents as those between 10 to 19 years, and young adults as 20 to 24 years. But even within adolescence, we break that down into younger adolescents who are 10 to 14 and older adolescents that are 15 to 19. And then we talk about youth that are between 15 to 24. So just one, I think, take-home point from this is when we look at the age groups in pediatric populations, we sort of have to think about who we're talking about. And when we look at mortality data, or when we look at a lot of our HIV-related information, we think about pediatrics as less than 15 and adults as over 15. And that's sort of somewhat of an artificial or arbitrary cutoff because we actually do have multiple categories. And across the age sort of life stages, there are different risks and different interventions that are needed. So I'm just going to come back to, again, the progress we've made and how much mortality has reduced, but also when we start looking from, sort of the right-hand side of this, we see that things are leveling off in terms of our reduction in mortality. And this is why initially in 2016 and 2017, it was recognized that there needed to be something additional in addition to testing and treatment that was needed to prevent mortality. And so it was really in 2016, 2017 that we've defined advanced HIV disease. And at the time, I think some of us may have forgotten this, but by 2016, we were just getting to guidance on introducing test and treat. So before 2016, many programs would actually wait to start treatment until people were already ill. And when we moved into test and treat, there was a recognition that number one, we had many more people to put on treatment, but that the people who were presenting for care had different needs. So there were those that were already very clinically stable on ART and just needed to continue their treatment. There were those that were presenting for care for the first time or returning to care, who were also well and needed to start treatment again. But we also had people who were not doing well on their treatment. And there were people who had already progressed to immune suppression and were returning with AIDS defining illnesses or low CD4 counts. And that's really what we called advanced HIV disease because the disease or the infection had progressed to a point where there was severe immunosuppression. So the recommendations that were needed were actually twofold at that time. It was also guidance was needed on how quickly ART should be initiated, because at the time we also worried about inflammatory reactions. And then we had to figure out what the right package of care was to reduce HIV-related morbidity and mortality. And I'm just going over this history a little bit to remind us of where that definition of advanced HIV disease came from. So in 2017, it was formally defined as for adults and adolescents and children older than 5 years. Advanced HIV disease is defined as a CD4 cell count that's either less than 200 cells per millimeter cubed or WHO stage 3 or 4 event. And then there was this other little note here that all children younger than 5 years old with HIV are considered as having advanced HIV disease. And I think that's something that gets carried over and we hear quite often. But I want to just clarify where that came from. And it's not necessarily because all children have severe immunosuppression. We know that many of them have faster progression in their disease progression and increased rates of mortality compared to adolescents and adults. And at the time, and even now, we are still finding children quite late. We're not identifying them early enough. So the majority of young children are presenting with severe immunosuppression. And then lastly, we are defining advanced HIV disease in terms of CD4 count. And for those of us who are pediatricians, we know that the immune system in children is a little different than what it is in adults. And we actually don't look at CD4 count in those younger than 5. We look at CD4 percentage, and we were changing our machines, and even now we're looking back at how do we bring back CD4 count, but CD4 count is not as helpful when we're looking to define sort of immune status in younger children. Now, this is not the case for older children. We can still use that definition of CD4 count or WHO stage 3 or 4 illness, but for those younger than 5, we do kind of this was sort of a definition almost of convenience. And but that said, there's also some caveats around that. And the reason why this came up is because, again, we started to categorize people as being on ART and being well or being unwell. And on the basis of that and the realization that there were different groups of or different populations that were affected that had different needs, we started rolling out differentiated service delivery packages of care. So different models of care according to the needs of the person. And at that time, for those that were stable, there was a lot of encouragement of providing multiple month dispensing or multi-month dispensing MMD. And one of the kind of criteria for having MMD was to not have AHD. And yet, children under 5 all had AHD. So this was a little bit of a confusion. And that's kind of why I'm spending time on this, because I do think this is a sort of an example of how kind of the way we labeled a population really had an impact on how they were able to access appropriate care. So we had to include a little bit of a side note here that those children who have been on treatment for more than a year that are clinically stable, they should not be considered to have this for the purpose of having MMD. Like we had to kind of walk around that to clarify, because again, we were leaving children out from what was actually quite a valuable intervention, particularly during COVID, where it was risky to go to the health facilities. We wanted to make sure that we could protect people from the risks of COVID infection, and providing multi-month dispensing was one way to do that. So again, I just want to spend some time clarifying when we talk about AHD in children, where those definitions came from. And so this is where we really felt like a specific guidance for children were needed for those with advanced HIV disease. And so this is where the Stop AIDS package of care for children and adolescents came in. Um, and again, when we talk about advanced HIV disease and the package of care, we focus mainly on those infections or um, or those infections or diseases that particularly affect people with immune suppression. So those who have a healthy immune system can fight off opportunistic infections. But once you're immune suppressed, it becomes much more difficult. And that's when we start to see infections or cancers like Kaposi sarcoma, or infections like PCP or PJP, where it doesn't affect people with a normal immune system or a healthy immune system, but it really, we start to see that. And that's in fact how HIV was first identified, because we were seeing infections in people that we didn't think we should be seeing them in. And so we came up with this mnemonic for pediatrics that was part of the Stop AIDS package. And part of the reason for that was we really wanted to make sure that providers, when they were seeing children, didn't get, most providers don't have a lot of experience with children. And so we wanted to make sure that we were covering all the elements that were needed to keep children healthy. And so this mnemonic was sort of, we came up with this mnemonic about STOP, which is screening, treatment, optimizing, and prevention. So again, it was just a way to remember what are the things that are essential for children. So when it comes to screening, we want to make sure that we screen for TB and malnutrition, because again, many of the children who are presenting with advanced HIV disease are suffering from severe acute malnutrition, which requires a very specific form of rehabilitation and management. And that's not to say that we don't see things that we see in adults. So we do see cryptococcal meningitis in adolescents and older children, but we don't see it as often in younger children. We want to make sure that we treat any active infections. So not only are we treating HIV, but if there's active tuberculosis, if there is some severe pneumonia, if there are severe bacterial infections, we want to make sure that we are managing all of those severe or treating all of those severe illnesses first and foremost. And we want to remind everyone that there is safe and very effective treatment for children. So we are past the days of having to use liquids or needing to refrigerate Kalitron. We actually have better, well-tolerated, less toxic, and easy to use optimal ARV formulations for children now, and we want to optimize the treatment that they're on, as well as their ongoing care, including adherence counseling for themselves and their families. And then lastly, we want to make sure that we prevent other infections. So that includes providing cotrimoxazole um, prophylaxis, TB preventative therapy, and as well as routine vaccination. And again, this is not something we focus on a lot in the field of HIV, but vaccinations are really kind of one of the cornerstones of public health and have really over the years prevented millions and millions of deaths. And childhood vaccinations in particular have really been a significant kind of has contributed significantly to decreases in childhood mortality. So this is just as important to consider for pediatrics. And so really, when we look at the Stop AIDS package, I don't want to make it out to be a very complicated package, but we want to remember here that we have to provide these children with the interventions that they need to prevent and manage illness that are related to HIV infection and and severe immunosuppression. But we don't want to forget that they're interventions that are intended to prevent and manage illness in all infants and children. And the reason I say this is again, because we're talking about integration of services, we're talking about holistic packages of care, and we're talking about making sure that we have one-stop shops or we have sort of mechanisms to deliver all the services that people need in a more convenient form. So I don't want to forget about those routine childhood interventions that are still very much needed. So we do have kind of a breakdown of what's needed. And again, pediatrics, we are considering that as all children and younger adolescents under the age of 15. And again, older children and and adolescents do experience cryptococcal meningitis. So that's not something that, that many of the interventions that we use in the adult package of care for advanced HIV disease are still very relevant. But there are a few things that are different, and some of those have to do with the pneumococcal vaccine that and uh, making sure that we have, if you look at the Stop AIDS tool sort of package, it is thinking about where we have to repeat vaccinations, where additional vaccinations may need to be considered, and where we don't have to repeat what we've done in adults. So cryptococcal antigen screening and fluconazole, I think we've put a lot of attention on this because I think this is still a significant cause of mortality and morbidity in adults and older children and adolescents, but we just don't see that in younger children. Doesn't mean it never happens, but it's not at a point where we feel that we need routine screening. But that's not to say that other things don't need to be done. And I want to sort of also close by just pointing out that with children and adults now living, sort of longer, healthier lives, and we have to think about kind of our services across a lifelong sort of care and support. So in children, growth and monitoring neurocognitive development gives you very important information about the health of a child, making sure that we are addressing psychosocial and mental illness issues, screening for other diseases that may occur, and very importantly, figuring out how to liaise with disability and rehabilitation services, because it's not just mortality, but it's the morbidity and often the accompanying disability that reduces the quality of life. And we should have interventions to address that. Children are also in schools, so we need to explore school-based programs on how we can better provide support. And we need to look into early childhood development platforms because, again, we know that provides us kind of a framework for how do we approach and provide the interventions that are most beneficial to young children. So that was a quick overview of pediatric advanced HIV disease. And just in conclusion, I want to finish with saying that we have advances in treatment now that have saved millions of lives, but we still need those services for advanced HIV disease because mortality has not been decreasing in recent years. Children under 5, by definition, we've defined them as having AHD because of their increased vulnerability, because we have limitations in the diagnostics that we use to evaluate immunosuppression, and that we also know that there are still multiple benefits that we can provide. And we don't have to limit some of the interventions that we have based on, things like MMD based on a category. And so I think that's why it's important to remember where that categorization came from. So I want to finish by just saying we know there is still need for more attention to address the disproportionate morbidity and mortality in children and adolescents. And so with that, thank you again for your attention and for inviting me to speak. And I'm just going to turn it over to my colleagues again. Thank you.
Thank you so much, Nandita, for that. I just want to point out a few things and emphasize the need to bend the mortality curves, but as well incidence. You know, many people used to refer to vertical transmission and the need to address that as the low-hanging fruit. Do you remember, like 20 years ago, it was, well, ARV therapy is complicated, but this we should be able to do easily. And as you can see, it's not the case in terms of the service coverage and being able to prevent unnecessary infections among children. So the other thing I want to point out, if we are going to bend the curves in terms of mortality, then we need the missing medical tools and the missing services. And also, as I say, to name what people are dying of, as Nandita did. So TB, pneumonia, severe bacterial infections, cryptococcal meningitis. We still would like to have more global health actors talk about what is killing people living with HIV, measure it, monitor it, treat, prevent, screen. And as Nandita said, acute malnutrition. Finally, I'd like to point out another policy issue, in addition to the missing medical tools or the lack of accordance with WHO recommendations, and that is the age of access. So at the HIV Policy Lab, we have tracked countries that still are not in accordance with WHO recommendation that any child, or adolescent rather, 12 years or older, should be able to access HIV services without the consent of a parent or guardian. This is access to HIV testing, HIV prevention, as well as sexual and reproductive health tools and services, and access to ART. So those need to be overcome. And if you're interested in collaborating with us, please write to, sorry, this sounds like a commercial, info@hivpolicylab.org, so we could bring about the policy reform we need, particularly for adolescents. Okay, over to our next speaker is Florence Anum. Florence is the co-director of the Global Network of People Living with HIV. And over to you, Florence, to talk about GMP Plus's work and with the Global Alliance to End AIDS in Children by 2030. Thank you. Oh, sorry, Florence. I totally neglected my other responsibility as moderator, which is to ask people if you have questions, please use the Q&A box. If you have comments, please also feel free to use the Q&A box. We will answer questions as we go and at the end. If you would like to direct your question to a specific person, as my comrade Tapiwa has done for Nandita, please do. Over to you, Florence.
Thanks, Sharona, and good morning, good afternoon, everyone. I just want to confirm you're seeing my screen and only my screen and not, I'm not, yeah, okay. So exciting to be here, and I just want to start by acknowledging that I am here on behalf of very many people, both community and not, and just to give a little bit of the why this matters to, I think, to me and to many colleagues I have interacted with over the years on advocacy, particularly for ensuring children's issues remain critically at the top of the agenda and are prioritized and resourced. I think it matters that children of mothers living with HIV, of mothers most vulnerable to HIV, and of or themselves living with HIV have a right to live and to thrive and to have the best life, just like everyone else. They are often not at the table. We are. And I think it is our joint and collaborative responsibility to make sure that any opportunity we get, we all make it a priority to speak up for children and ensure that they are protected from HIV and the impact of AIDS and that they don't die. It is irresponsible for children to die now. We have so much, we've come so far. Having finished with that, I want to say that I will speak about the Global Alliance to End AIDS in Children and Adolescents by 2030 as an entry point of one of the things we can do to work collaboratively with policymakers, communities, and governments to ensure that we are doing our best for children affected by and living with HIV. And this is my perspective as GNP+, but also understanding that sitting in the Global Alliance is ICW, the International Community of Women Living with HIV, and Y+ Global, who are also members of the Global Alliance, which brings together UNAIDS, UNICEF, WHO, Global Fund, PEPFAR, and EGPAF, and coming together on something I will talk to you about. And I think we will start by, I can't move my slides. Just a second. There we go. I think Dr. Nandita spoke a lot about the targets, the statistics of why this matters to us. We are off target in reaching children, and the number of new infections among children, though declining, not fast enough. But there is also a huge amount of children who are meant to be on treatment who are not on treatment. And what that means is we are missing children. We are missing mothers of children. To find children, you need to find their moms. We are either missing the moms or we are missing the mothers of children in the various aspects through reproductive health or sexual and reproductive health and rights cascade. And we need to sort of do better to be able to reach children, have them tested, have them identified and put on treatment and supported to remain at the end so that we are able to address the numbers that we see of here. I think one of the things that we see from data is that the principle of ensuring no child is left behind will not be realized if we do not have conversations about where exactly are they being left behind. And this will begin to have us look at data a little bit more intentionally. Which children, whose children, where? And some of the data we are seeing here is showing how 50% of new infections happening in 6 countries, for example. And then maybe that's where we need to start to talk to the different players and the community themselves. What are the challenges? And the women living with HIV themselves, what are the challenges of getting to accessing care? Because then when we look at data a little bit more intentionally and we start to disaggregate data and look at where the resources are going, then it could be one of the ways that we begin to address the issues of unmet needs, missed opportunities for case finding and finding children and ensuring they're okay. I think one of the things that has also been a discussion with looking at this data in this way has been what other opportunities have been missed for accessing women across the antenatal care. Generally, even women who are not living with HIV at the time of pregnancy and delivery, but also acquire HIV probably during the time of breastfeeding. And so these are some of the conversations that from our community side we use, and the data that we have, we use to sort of enhance our treatment literacy, but also build health awareness around antenatal care processes amongst women at community level. So I think I think Dr. Shafiq must probably have these slides, so I won't belabor on the fact where did we come from to get to the Global Alliance now. But I think it's not new. What I will say is, for those of us who've been in the field, we know we have transitioned from EMTCT, the global plan, to start free, stay free, AIDS free, to where we are at now. There are intricate differences around the multisectoral coming together of partners in the Global Alliance to end AIDS in children. By 2030, it's 9 years and not 5 years as the previous ones. It's looking at what we have achieved so far and trying to sustain those, but also critically understanding what are the gaps or what did we not do well and how can we build up on those. And I think from our community side, it has always been to highlight the missed opportunities for addressing the social barriers and the community engagement and leadership, particularly of women and girls living with HIV, in ensuring that we reach our population with the right information and we do our best to identify where the structural barriers are and to mitigate those structural barriers to do our bit to ending AIDS in children. But also the specific need of data and who's collecting that data, and to understand that community data is also critical data, most of it operational, but also with the expanded opportunities now around community-led monitoring that many colleagues are doing at different levels, at country level, to tap onto those opportunities. I think one of the things, and I have to say, these slides were shared with a group of Global Alliance ambassadors, and it's just to sort of show the core structure for how this work is happening. And it looks at the purpose, which is to end AIDS in children and adolescents by 2030, but for who and with who? With people, and to be clear on the processes of how that will be done, and the performance, which is to measure consistently and continuously. How are we doing? What can we improve on? And I think the mechanisms for which the Global Alliance to End AIDS in Children is operating is really embedded on these structures. So I think the work is around 4 pillars. And the first one is early testing and optimized treatment and care for children. So basically the testing pillar and all of the work around case finding, identifying children or mothers living with HIV and having them on treatment, identifying opportunities for meeting the women at the point of need. So all of the point of care testing and everything will be captured within pillar 1. Pillar 2 is around closing the treatment gap and optimizing continuity of treatment. So what are the adherence challenges women are facing, or children are facing, or caregivers are facing? What are the treatment gap issues that we need to address, particularly also with healthcare providers? And there's a lot of considerably good work that's happening with colleagues at PATA to try and bring to light some of the challenges and missed opportunities that healthcare workers are facing and could use to enhance closing the gap. Pillar 3 is around preventing new infections among pregnant and breastfeeding children and women. And this is where we are starting now to talk about children of key populations, children of women most at risk of HIV, but not included normally in discussions around pediatric treatment and prevention issues, and also linking the barriers between, the integrating linkages between prevention and treatment to reach women and girls. And then pillar 4, which is where most of our community work really lies, is addressing structural barriers that hinder access to services. And if you can look at the populations we are hoping to reach with the work, it's children and adolescents living with HIV, children perinatally exposed to HIV, pregnant and breastfeeding girls, and women living with HIV. The aspect of children, having children, is also something that we need to understand that we have found we have to face, particularly with the increased gender-based violence around COVID. And there's a lot of women, young women and teen moms that have come through as a result of that, and what services are being made available for young teen moms, because they're not the same services needed for adult moms. And then pregnant and breastfeeding girls and women who are HIV negative but at risk of HIV infection. And then I don't want to go into the details, but just to say that there's a whole structure for how this works. Some of us sit at the steering committee, but there's also regional hubs which have representatives of community of women living with HIV affiliated and linked to ICW and Y+. ISA has a regional gap. Eastern Southern Africa, Western Central Africa has a regional hub. Under those hubs, there are country global alliance chapters, and there are representatives of women living with HIV and champions for children sitting in those representing structures to just ensure that we are represented, we are speaking up on the realities of communities, and there are mechanisms from which to report to each other bi-weekly, monthly, across the pillars and across the structures that you see on board. I will not go into the details now. The countries on the first phase of the Global Alliance are also indicated on the slides, which we will share. Sorry about that. Again, so just quickly, what have we been able to do? Last year, country action plans were developed, highly with support from UNICEF, WHO, and UNAIDS. We participated in these processes, and these action plans aligned in time for the PEPFAR COP and the Global Fund country applications. Just before that, we did engage into the DAR declaration process. Countries met in Dar es Salaam, countries from the 12 priority countries of phase 1 of the Global Alliance, and came up with these 10 points around the collective commitment on ending AIDS in children by 2030. There are specific country commitments that we are all tracking and which have definitely gone into making the country plans. And I think countries like Kenya have really progressed. I know while we were there last month, they did inform us that their target is actually to achieve these goals by 2027. So these different countries are actually doing different pieces guided by these commitments. But it's also an opportunity for us as community to hold countries accountable. I think I feel like for us to achieve all of this, there is a mix of different things that have to happen. The political buy-in is important. We started off in Dar es Salaam, but we don't need to stop. We need to keep continuing. The role of country ownership is particularly important because even though we have global wins in terms of policy, the implementation is at country level. The services that will matter to the women are actually at country level. And so the country ownership is really important to ensure that everything that is possibly available, diagnostics, treatment, the optimized versions of them actually are factored, prioritized, and resourced so that people are able to address or access these services and we achieve our goals. Donor alignment, really important because then that would determine how pricing, how access happens. The primary leadership of community is also critical. And I mean, beyond just sharing our stories, I think leading different pieces is important. And that's why the work around doing the Global Alliance Advocacy and Communication Plan alongside UNICEF and the others, the work around led by ICW on leading the Community Oversight Task Force, which is a group of women that will work to ensure that everything is strategically aligned across the different pillars. And also the work that we are doing collectively around champions for children to make sure that there are different people speaking to and addressing aspects of children in country supported by VIV is one of these things. Prioritizing action plans, of course, monitoring impact and having accountability frameworks is important. I think there's a spotlight around what has happened in the Eastern Southern Africa Regional Hub, which I won't go into now. I believe these slides will be shared, but I just wanted to demonstrate that collectively as a team who plays into what different areas. But I think the slide that is important is to just see the reach and the actual collaboration that happens at regional level to be able to bring everyone on board in these processes. In summary, I think some of the challenges that we need to prioritize are around children being missed out on treatment. We need to get 43% of children living with HIV on treatment, and we need to figure out how to do that and what are the challenges that stop it from happening. The viral suppression, load suppression remains worse for children compared to adults. The coverage of ART in pregnant women has stagnated. So how do we identify what challenges still remain and who is being missed so that we can close that gap? I spoke about adolescent girls and women acquiring HIV in pregnancy and breastfeeding, and of course, the persistent stigma and discrimination. This is just like a framework, a results framework also developed collaboratively with everyone in the Global Alliance that we are using to monitor and identify how are we doing, who's where, what can we do. There are so many things, it's just 1 year in to learn from the process so far. And I believe that there is a lot of partners in the call right now who can help answer any questions that there are. And I will stop there.
Thank you so much, Florence. And we will make all the slides from the presenters available. This webinar is also being recorded and will be available to anyone that registered. So you will receive the slides and the link to the recording. Let me now turn to our next speaker, Dr. Shafiq Essagi. Shafiq will be talking about some of the persistent challenges, and it's fantastic, of course, to be able to hear more again about the Global Alliance and that fantastic collaboration and push for accountability. Over to you, Shafiq. And please, if you have questions, keep posting them in the chat, and the panelists, all of them, will respond in kind. Thank you.
Thank you very much, Sharon, and what a pleasure to be invited to speak with all of you today. Fantastic questions coming into the Q&A. It's great to see so much engagement around a theme that is very close to my heart. I've been a pediatric HIV doctor for longer than I can remember. And, you know, hearing some of this discussion this morning makes me realize that, you know, we still have a long way to go. And many of the issues that we have been trying to address and deal with have been there for a long time. So it's fantastic to see others joining us in this effort to try to address the challenges of pediatric HIV together. A lot of the slides that you've seen already were ones that that I was going to also show you. That's great because we're all speaking from the same playbook, and it means that we have more time to potentially discuss some of these themes. So I will run through some of the progress, priorities, and challenges quickly, and then see if we can have some time left at the end for further dive. Every 5 years, UNAIDS develops an AIDS strategy that serves as a bit of a roadmap for the global AIDS response. And the current one, which runs from 21 to 26, places ending inequity as central to the mission to end AIDS globally. And UNAIDS rightly has focused this on the need to ensure that our programming is human-centered and rights-based. And the strategy focuses a lot on populations that have been historically neglected in the global response, including key populations and migrants. But my thesis is that some of the greatest inequities are those that are faced by children. Now, you've seen these two graphs on the right. We are way off target to end AIDS in children. Vertical transmission certainly has fallen, but as Nandita pointed out, we've sort of stabilized at around 80% of antiretroviral treatment coverage amongst pregnant women. And Sharon, you reminded us that it was in PMTCT that we saw the very first use of antiretrovirals in low and middle income countries. And that was over 25 years ago. But despite all of these decades of programming and progress, we're still seeing 130,000 new infections in children occurring every year. A significant fall, but too many for us to really be complacent about that success. Nandita and Florence also highlighted the discrepancy in terms of treatment in children versus adults. And I also want to showcase the fact that, you know, there are fantastic performers, countries that have made real strides in achieving much better access for children. But then there are other countries where we see really a stagnation of, of the pediatric treatment response. And, and I want to point out Western Central Africa as an area that causes us concern. You know, historically, it's always been Eastern and Southern Africa that was the epicenter of the epidemic. But I think as those countries in Eastern and Southern Africa begun to do better and better, so we're beginning to see that countries in West and Central Africa are really lagging further and further behind. And the unmet burden of need is increasingly shifting over to the West and Central Africa region. Nandita also shared all of these statistics with you, so I won't belabor them. But the point here is that across the whole cascade of care, from testing to treatment to maintaining viral suppression, children are 20 or 30 points behind their adult peers. And that explains why, although children are only about 3% of all people living with HIV, they account for 14% of all deaths due to HIV. Now, we're here to talk about morbidity as well as mortality. And I want to remind us, as Sharon Ann also said, that children have always been a high priority, right? If you go back in history and look at all the documents and the policies that people were putting out, it was always, you know, let's prevent the scourge of HIV from affecting the little children. This was not something that was a hard sell for people. And yet, despite it being a high priority, it remains true to say that the life-saving drugs that we needed for children were not approved for years, sometimes decades, after they were in widespread use in adults. The service delivery innovations that have enabled us to achieve, in some countries, 95% coverage of antiretroviral treatment in adults as well as in pregnant women have not been realized for children. Pediatric treatment remains fairly centralized, even in the high burden HIV countries. And in most parts of the world, adults can readily access testing that is free and confidential, and indeed happens at the point of care. This is not true for children and adolescents. And I think the reasons behind that are clear. Some of them are technical, but some of them are also around the fact that children need to have an adult with them that can provide consent. And children often need an adult to actually bring them to the health facility and request testing. So I want to remind us that these delays in diagnosis and treatment, suboptimal therapies, and weak systems to support retention that are causing this lag between children and adults across the whole continuum of care mean that morbidity is much higher in children compared to adults. So we've talked about the Global Alliance already, and the vision that the Global Alliance represents. And I just want to underscore that this is a successor to the Global Plan and the 3 Frees, these global initiatives that we have seen in the past, and that have been really important to galvanize action. What we've tried to do in the Global Alliance is to take the lessons that we've learned from the successes that we saw during 3 Frees and the era of the Global Plan, and try to make them central to the structuring of the Global Alliance. And And those lessons of the importance of country buy-in, senior political leadership from organizations like WHO, like UNICEF, alignment with donors so that we can actually walk the talk with money instead of just talking about the things that are important. Focus action so that we're clear about where the gaps really are and engage with communities to try to make change. What we're trying to do is to learn from the past to build momentum over a longer period of time. So the Alliance was launched in 22, and that gives us 9 years, which we're dividing into 3 phases to try to achieve these objectives. We want to promote country leadership and community ownership, and we don't want to replace any existing initiatives that are ongoing. The Rome Action Plan is absolutely critical. Africa Reach, absolutely critical. All of these initiatives, we want to work with them to collaborate and celebrate our shared success when that happens. We've talked about the pillars of the Alliance already, and I just want to note that within each of these pillars, countries have already done a good amount of work to define the key interventions that they want to take forwards for prioritization. Now, here in this webinar, we're obviously focusing on the treatment and care piece, Pillar 1, which looks at optimizing antiretroviral treatment and the quality of care for children and adolescents. But the pillars track across the prevention of HIV among children, preventing HIV in women at risk, and addressing some of the structural challenges that have long hampered us in the uptake and access to services. And among all of these interventions, if we focus on Pillar 1, I think there are 3 strategies that I want to leave you with as sort of the things that we could do quickly to try to address some of the challenges, close the gaps, and incidentally improve the rates of advanced HIV disease among children. So the first strategy is really scaling up a multimodal approach to HIV testing. And this should include virologic testing, but for too long, early infant diagnosis has been the end-all of pediatric HIV testing. It doesn't need to be. Serologic testing of older children is critically important. And in some of the work that we've done with partners in many countries that are part of the Alliance, we have seen the value in strategies such as family index testing to try to really find children that were missed by infant testing. Without fail, linking all newly diagnosed children to treatment. Surprisingly, in some countries, this remains a gap, especially where treatment is quite centralized, whereas testing through EID and other systems is decentralized and much more widely available. So in South Africa, for example, there is a 30% drop-off between the number of children that know their status or whose status is known and the proportion of those children who are able to access treatment. And then finally, the third strategy is, I think, to replace outdated pediatric treatment regimens with optimized approaches to treatment for children. So let me close there and hand it back to you, Sharon Ann, and we remain with you. Thank you for your commitment.
Thank you so much, Shafiq. We are also going to stay on in order to answer all of the questions after we hear from the next panelist. So again, if you have them in writing, and then we can spend some time to hear from the panelists in response, because some of the questions are a little bit complex. So let me hand over now to Edna Tembo. And Edna is the Executive Director of the Coalition of Women Living with HIV/AIDS in Malawi. So Edna, over to you, my friend.
Yeah, thank you very much, Sharon Ann. Thank you. Good good morning, good afternoon, depending on wherever you are. My presentation is focusing on communities, what communities are doing in order to fight pediatric AIDS in Malawi. Next slide. Yeah. Especially the roles of community in stopping AIDS. I'll not go into details of everything, but as you know, communities have a role in advocating for change as in policy, and also making sure that they are working in partnership with the government, donors, and all those people who are responsible for policies as well as service provision. So in this slide, I've also mentioned some of the things that communities will do, but because of time, I'll not go through them. Let me jump to the last two slides at the end. With the government to hold them accountable, donor communities, as well as also collaborating with other NGOs in the community. So my last slide was to call on the action. What are we saying as communities? We are calling for rapid transition of optimal treatment for children. Especially, we have seen that children are a group that is mostly left out because they don't have voices in the spaces. So we are calling that the children should be considered and make sure that optimal treatment is given to them, as well as also looking at issues of comorbidities, as the previous speakers talked about, the TB, meningitis, so that children are getting optimal treatment. And the next call is to strengthen capacity, access, availability, affordability, and also to make sure that screening treatment is adequately spread into all the facilities so that children are given better treatment and also they are managed early before the HD becomes worse. And we are also asking our government and donor community to have equity in distribution of diagnostics and commodities for AHD. As civil society, we have engaged with various donors, especially PEPFAR and Global Fund, to make sure that they are supporting AHD in providing commodities. So our call, we are ending it as ending the HIV epidemic is a critical goal that requires collective effort and commitment. So communities of PLHIV and their peers are instrumental in sustaining engagement, advocating for health equity, and ensuring human rights. So government, donors, and actors must continue to support communities, a vital role in ending advanced HIV, especially focusing on children who are most left out, and also they are a critical population. I think let me stop there because of time. I hope next time I'll be going through the details of my presentation. Thank you, and over.
Actually, Edna, can you go through the details now? Because your work in Malawi is so important and what you've been able to accomplish. So the holding government to account and leveraging those global health initiatives. Thank you.
All right, thank you. Can I have the slides back?
So if you can go up to holding government to account. Thank you.
Yeah, okay. Thank you very much for giving me this opportunity. On holding government to account, what we did is to influence the government and the guideline committees to include the optimal cryptococcal meningitis treatment regimen and induction with the single high dose liposomal amphotericin B, and also to make sure that daily maintenance oral therapy of fluticasone and fluconazole is available. We also engaged in different national technical working groups addressing HIV and pediatrics. We have the AHD technical working group, the pediatric HIV working group, and also HIV treatment, care, and support technical working groups, where we are members, and we are also invited every quarter to give updates and also get updates from implementing partners. We have also engaged and participated in the AHD and EMTCT steering group. As Coalition of Women, we were given that opportunity to be in this steering group of AHD and EMTCT. And also we take part in AHD validation processes in the country. And we have also engaged the government of Malawi to improve the pace of scaling up who recommended AHD package of care, including for children. We know in Malawi, the scale up of AHD has been very slow. Currently, we have 529 sites out of 850 ART service sites. So we are advocating and also engaging government to make sure that they scale up so that those who are not able to access the services should have these services closer to them. And the government also to include HD in the clinical HIV management guidelines, which they have done, and also emphasizing on the screening of cryptococcal and TB as integration screening. And also there is a pilot on stool screening for TB in children in 3 districts, where because diagnosing TB in children has been a challenge. So there's this pilot, which they are planning to scale up if all goes well. And it has started in only 3 districts at the moment. And also we are engaging in advocating for scale up of TPT, especially 3HP, which is a shorter regimen, as most of the facilities are still giving INH, which most of the recipients of care are not tolerating. So we are advocating for 3HP, which is shorter, and the people are happy with 3HP. And the government of Malawi to also prioritize AHD in their policies, which they have done. And during the G7, they have also included AHD as a priority in the concept. Next slide. Yeah, so on donor engagement and influence, under Global Fund, we have influenced the government as well as CCM to include the AHD package, which I've already mentioned that it has been included. And the Global Fund has also managed to recruit some of the human resource to support in the testing, and also to support AHD commodities 100%, which is a plus on our side. And also we are happy. What we have to do now is just to make sure that we are monitoring these promises and also these issues which they have put in the concept note. And also under PEPFAR, we have also made sure that PEPFAR is supporting AHD package in their implementing sites. And the PEPFAR has also increased the sites providing AHD from 208 to 529, and also increased the integrated molecular testing sites of TB, HIV, and cryptococcal meningitis to 24, with another additional 4 molecular sites. Next slide. Yeah, so on collaborations with other communities and civil society organizations, we have made sure that we are raising awareness on advanced HIV/AIDS, missing medical tools, as well as who recommended AHD package of care among civil society networks. As a leading member of the civil society organization, we are also part of the Fight AIDS Coalition, and we are using the materials and tools from the coalition such as briefs and asks to engage with PEPFAR, UNAIDS Global Fund. And I think last year we had a brief which was sent to PEPFAR to make sure that they are including HD commodities, drugs, and all that, which we delivered with our colleagues, FACT, who are also part of the TB CSO network in Malawi. We are also leading in the draft. We also led in the drafting and the inclusion of HD sections on behalf of CSOs, as well as also the community annex, which is the very important annex for Global Fund, which requires community asks. So we were part of that, and also part of the LIULA too, which is the PEPFAR COP document, which we present with our asks, and also make sure that we are following. And this document, it's like a reference for us. And when we go to PEPFAR, we usually produce this document to make sure that we are following with them. And we are also part of other networks and coalitions advocating for advanced HIV, and in some specific like TB, like in TB aims, Impact for TB, Smart for TB. And we are also a campus coalition team where we are also doing a campaign on AHD in Malawi. And Nicola is leading that campaign on AHD in Malawi. So collaborations with FACT, TAG, and Health Gap in participating in calls and events at regional level, and also learning and information sharing has also made us to have more rich information, which has guided us when we are making our asks and also bargaining for AHD scale up in the facilities. Next. Yeah, I think I've already talked on this one, on the asks, yeah. So thank you very much.
Thank you so much, Edna. You showed the multiple ways in which national organizations, community-based organizations, are making impact on policy and practices, and both in terms of direct with other communities, direct with government, and with the global health initiatives. So thank you so much for your work. And I also want to acknowledge some of the other FACT members, that's the Fight AIDS Coalition, that are on the webinar and have been doing work also at the national level. So Patricia in Kenya, Olaide in Nigeria, Mamoletsi in Lesotho, Tapiwa in Zimbabwe, and others. Sorry if I neglected to call your name. If you would like to join FACT, write us at info@hivpolicylab.org. We have monthly community of practice calls, and we will not relent, frankly. So let's get to your questions. Thank you for those that are staying on. Shafiq had to drop, but Nandita, if I can ask you to chip away, thanks so much for answering many of the questions already in writing. If I could ask you to chip away at some of the other questions, that would be great. And then Florence, over to you to respond to a question and close. Please, Nandita. Sorry, you have so many questions.
No, they're great questions. And I actually,
yeah.
I have to say, as a pediatrician, I'm happy to see these questions come in because we don't talk about this enough. And I think there are a few people who, are asking great questions about, why is this happening? And it's very shocking when you see it because we don't see, the number of children we now have living with HIV are very relatively small. I mean, we have done, I don't want to sort of not count the incredible progress we've made in eliminating new transmissions or new vertical transmissions and seeing how far we've gotten in this field. But the truth is, yes, sometimes these populations, these small populations, are hidden. And just to some of the questions around, what are the systems that are needed or the interventions needed to address serious bacterial infections? And that's a great question, but the answer is actually it's strengthening our health system, right? Because we need to know, we need surveillance to know what kind of bacteria are in the environment, what's in the hospital. Do we have the appropriate infection control precautions? Because we know that, a lot of these infections are actually can happen in the hospital. We need to know what specifically are affecting children living with HIV with immune suppression versus, children living with HIV are just as susceptible to other childhood illnesses, and if anything, they will they have more severe outcomes. And so some of that is overall health system strengthening, but it also is recognizing that, children don't have a voice, they don't vote. They're part of nobody's constituency in a sense. And so when we really counted a lot on community voices coming forward to shout and argue and fight for the rights that the community has, but we don't have children doing it because they're children and they can't. And so unless we are doing that, nothing will change. I also want to point out, I think there were some good questions around why is it we know everyone here who is a parent, it's unimaginable to think that your child could be sick and you wouldn't seek care, or it's unimaginable to think that. And what happens is, again, there are all the barriers to accessing care that women face during pregnancy or seeking treatment. Those still are also there when a child is sick, whether it's distance, whether it's cost, whether it's permission to take her child to the hospital. In many settings, women don't have the right to even do that. And then it's also how prepared is the health system? How prepared are the providers to provide pediatric care? And I'll say, and again, this is just my observation, when something comes up around pediatrics, someone who hasn't been trained in child health sort of gets scared. So it's almost like fear of taking care of children because you don't understand what's needed. And that's to say we need to do a better job of demystifying it. And so that's kind of another reason for this is I think we do need to think about making sure that providers and frontline providers in particular know how to recognize illness in children, know what are the first few steps that you need to take. And again, that helps with feeling prepared, feeling like this is something that can be handled. Many of these children are actually brought to the hospital, and either they die in the hospital or we know they're discharged and they die at home. So clearly there's something, this is, I think, a very complicated situation, but we can't ignore it. I think the fact that there's multiple things that are needed doesn't mean that we just sort of brush it aside and wait for another system to fix it, because that system isn't there. And I think that comes back to some of the other questions around, kind of the risks for women who have incident infection during breastfeeding. And we know during incident infection, you have a higher viral load and much more likely to transmit onwards. So yes, that's a very risky time for a mother and a child. Not only is does the mother have a newly acquired infection, but she has a high risk of transmitting it onwards. Yet in many settings, we think about testing at least once in ANC, and we don't think about testing after that. So again, some countries are now introducing policies to suggest or recommend ongoing testing or regular testing in women who are pregnant or breastfeeding, even if they've had a previous negative HIV test, but we don't do that enough. So I'm not sure if there are a couple other questions here around, how do we find the missing children? I think that's a huge question, but sort of just to add on to that, how do we find those children, and then how do we retain them in care? Because one of the issues we have with our data systems is we're not tracking people over time. So there was a question there about what do we do with adolescents who then transition to adult care? And that's an age discrepancy. There's no huge difference between a 15-year-old and a 16-year-old, but it's the way we define define these populations. And then we're not following them over time. So a child who enters the clinic at 10 years old, we don't know if that same child has continued in care until, for the next 10 years. and at 20 is still in that clinic. We are just looking cross-sectionally across how many children are in care now, how many children are in care next year, and not thinking about how many of them have actually transitioned into the adult population. So some of it has to do with the way we track and the way we monitor. And I think those are some of the things we have to think about when it comes to understanding what's actually happening and in addressing those challenges. So we see, like right now, we're hearing much more about adults who drop out of care and then come back later. We don't talk about that in children, but we know that many children are not, they don't even know their own status. Disclosure is another big issue. I think we could talk for probably weeks about pediatric HIV. So I think that's a warning to anyone who invites pediatricians to talk about this, because we don't talk about it enough. So just to say, I really appreciate everyone's questions and everyone who stayed on to listen. I think this is of critical importance, and I don't think we have achieved anything in HIV unless we actually reach our most vulnerable populations. Thank you.
Thank you so much, Nandita. And I will take you up on the offer both to do this webinar, thank you, but also if you could join a future Fight AIDS Coalition call to take more questions, and we'll even transcribe that for everybody. Florence, over to you, please.
I think since we are over time, I will just echo Dr. Nandita's point of we can talk about this for days. We don't always get time to talk about children, but also to acknowledge my colleague Edna and all the incredible work that's happening. And I'll just start from there for the work that Edna spoke about, and that's the kind of work that we need at country level that other colleagues are doing. It needs to be funded, it needs to be resourced, it needs to be progressively funded, that it fits with the national systems. And that's where we can be able to measure growth and be able to do the accountability work needed for policy to translate into action, but often remains unsupported consistently. And so there's touch points where it's active, it's not, it's active, it's not, because it depends on which country is prioritizing or has support for community-led interventions. And just to start that is a need that we have to address. And if we really are interested in community leadership across this is what Edna presented right now, is the version of community leadership that we would need for all the countries to be able to get to some point of success. I think that the topics have been covered in different parts. I just wanted to say there are so many opportunities that I find missed because the children's piece of work remains removed from, I don't know whether it's the integration conversation. For example, there's opportunities around ensuring we are very consistent with information around prevention during pregnancy and breastfeeding, even using PrEP during pregnancy and breastfeeding, and that remains removed because of the narrative around what PrEP is, who can use PrEP, and I think there's a lot of work that we need to do to try and shape communities' understanding of interventions and opportunities. I don't even think we talk about advanced HIV disease for children. It's never happened. This is my first time to talk about it for children. We don't. So for someone to even understand that this is something I need to be aware of for my child as a community member, it's non-existent. And so for me, I think the understanding of advanced HIV disease remains limited across the communities, but it's never happened for children. And maybe we need to start there to let people at community level understand and to be on the lookout, but also to use that as an opportunity to motivate treatment and motivate adherence and to see how partners come together for this. Just to say there's a lot of work ahead. And I think the group in here, the 80-something of us in here are the group to push this forward. Thank you for having me. Thanks.
Thank you so much, Florence. One of my heroes, Dr. Alan Berkman, said, the last time I saw him was, I think we made a mistake in 1999 when we started campaigning for global access to ARVs. We made it about everyone, which people took to mean adults. We should have made it about children, because if you focus on the most vulnerable, if you focus on those that are otherwise invisible, then you have a true articulation of progress, or the lack thereof. And he referred to children living with HIV, dying of AIDS. You heard 50% under the age of 2, if they don't have access to antiretroviral therapy, are equivalent to footprints in the sand. They go away with the next tide. So even the numbers that you have heard from Nandita, from Shafiq, they are vastly underreported. So children don't have political power, as Nandita said, but certainly their champions can, by insisting that these deadly gaps be closed. Thank you so much for spending this time with us. Thank you for the work you're doing, whatever the acronym. FAC, Fight AIDS Coalition, GMP Plus, WHO, UNICEF, the Global Alliance. Chai is on here, and I want to thank Chai for where they are working on this issue, partnering with local civil society groups, as well as others. So thank you so much. We'll send out the slides, we'll send out the recording, and we will, of course, press on. Thank you.